So this one's going to talk about anger and abuse. I'm going to try to keep it really short. I want everyone to be able to pause and take breaks as needed. I know this is a super sensitive topic for a lot of people, including myself. So the topics we're going to talk about is anger and aggression, family and community violence, and sexual assault, and our role as a nurse within these. So anger. There's a difference between anger and aggression. Aggression is going to be the deliberate attempt to harm or destroy something. Anger is just that intense emotion. Anger is a normal feeling and is an emotional response to frustration. And it can be positive. If there is an unfair or wrongdoing that needs to be corrected, and it can be expressed in a healthy manner, that's healthy anger. Anger becomes unhealthy when it's expressed poorly, such as aggressive behaviors, hitting, cursing, swearing, things like that. Okay. So we have our categories, which is pre-assaultive, assaultive, and post-assaultive. During the pre-assaultive phase, this is when you see your patient start going back and forth, pacing, getting tense, getting anxious, getting hyper, getting verbally abusive. Assaultive is when an act of violence occurs, and this is typically when a restraint or seclusion may be required. And then post-assaultive is when everybody has calmed down and we have a conversation with the patient about who, what, when, where, and why, different ways to cope with this, and different ways to express our emotions. For seclusions and restraints, this doesn't really change just because it's for aggression, but we do have to remember our seclusion and restraint guidelines. They do not change for this at all. Okay, so some comorbidities that typically come with excessive anger and aggression is going to be our depression, our substance use. When somebody is on substances, they can act in a different way. That bipolar disorder, especially in that manic phase. During PTSD, especially during a trigger or a flashback. Our cognitive disorders, our delirium and dementia patients. Remember that sundowning and all of that. Personality disorders, especially when they can't get what they want and that manipulation's not happening. Someone who's in psychosis, so they may get aggressive, especially if they are seeing things differently than reality. So they may see something very threatening and feel that they need to respond aggressively. We also have the limited coping abilities. So those who don't know how to cope with their anger, cope with their emotions, use positive outlets. These are our high-risk individuals as well. Some risk factors that typically come along with aggression and anger is going to be a past history of aggression, someone who has poor impulse control and violence. This could be because of a comorbidity. We have our living in a violent environment. If you live in an environment where you're fighting for your life every day, you're going to become more violent, even when situations don't call for it. In a limit setting by a nurse in a therapeutic milieu. So this is when we're on the floor and we set limits. Remember, that was a huge piece of the personality disorder treatment, is setting those boundaries. But this can cause aggression, especially early on in treatment. So it's important to kind of remember that even though we trigger it, sometimes it's okay, we got to work through it. So things that we're going to see when someone's getting triggered or the expected findings, that pacing and restlessness. Hypersensitivity, they may be easily offended, easily upset. extreme eye contact or lack of eye contact, poor facial expressions, body language that says I'm angry, rapid breathing, posturing, verbal cues like yelling, screaming, and then of course a lot of times we may have intoxication with drugs or alcohol. As a nurse on the unit, our biggest thing is we want to provide a safe environment to the client who is being aggressive and the clients and other clients and staff on the unit as well. We want to assess for triggers that may escalate it, and we need to perform a self-awareness assessment on ourselves. One of the hardest things is getting punched or getting even just postured at or jumped at, and then having to go and be therapeutic with this client. So when someone does start escalating, the first thing we want to do is respond quickly. We want to maintain calm, cool, and collected, and we want to try to get the client to express their feelings verbally, using reflection, silence, active listening, things like that. That's not aggressive. We want to allow as much personal space that safety allows. And of course, maintain eye contact, sitting at the same level, communicating honestly, sincerely, and non-aggressively. We're not going to use accusatory or threatening statements. Oh, if you don't calm down, we're going to seclude you. That's not going to work. That's just going to make them more mad. We're going to describe options clearly and offer reasonable choices. So that would be, all right, so you're very angry. Do you want to sit in here and talk with me about it? Do you want to go to your room for a few minutes? Or would you like to go to the gym and shoot some basketball to try to get some of this aggression out? So those are some options you can give. Of course, we want to set limits. Tell the client that I need you to stop yelling at me and walk with me so we can talk. You're not threatening them, you're not yelling at them, you just need to tell them what you need and what you're doing. We may use physical activities such as walking or going to the gym, running, shooting basketballs to kind of de-escalate the anger. We do want to let them know that there are consequences to the behavior without being threatening. And then, of course, if things don't work, we're going to have to use pharmacological interventions, which may be forced medications, and we may have to do restraint or seclusion. But that's again, we want to work through every possible alternative before we get to restraint, seclusion, and involuntary medication. After the episode of violence, we really need to debrief. Debriefing was one of my, I hated that I had to do it, but I loved doing it because it helped my staff process and just get their emotions out, because these are really hard times. So making sure your staff in your area can debrief and everyone's okay. We also want to debrief with the patient when they're ready to talk about it. As far as our medications that we may give, especially in an acute situation, like if we're forcing meds via injection, we may use first or second generation antipsychotic, like haloperidol, olanzapine, ziprasidone, things like that. And all of our risk factors, all of our nursing interventions for those drugs stay in place. As far as treating and preventing anger, we need to treat some of that underlying disorder. So one of those comorbidities. So this could mean maintaining antipsychotics if the problem is psychosis. It could be lithium or a anticonvulsant for mood stabilization if the comorbidity is bipolar. It could be an SSRI if our underlying is depression, substance use, PTSD, things like that, anxiety. So it just depends. After the acute issue, there's no like treatment for aggression. We have to treat the underlying source. Now we're going to talk about family and community violence. So violence from one person to another is typically going to involve a abuse of power. So we have a cycle of violence. This is typically in spouse or partner violence, and it's pretty predictable. We have the tension building phase. This is where the abuser is going to have minor episodes of anger, little verbal outbursts, maybe a little pushing and shoving, but nothing serious. We're going to have tension growing, and both partners want to reduce it. Typically, the abuser may start drinking or using drugs, and the victim may dismiss the significance of the violence. Oh, I know he's yelling and angry, but he's just had such a hard time at work. I know it's nothing. Things like that. And then, of course, they are going to they're going to take blame for what's happening. This is their fault. They feel this is their fault, and they are responsible for fixing the problem. After that, the tension's going to build so much that serious battering now takes place. This is going to be our main stage of violence. During this time, the victim may feel the need to cover up wounds or injuries, and they may have to get help. This is the shortest stage and the most violent. Okay. After the violent stage comes the honeymoon phase. This is where everything is great. I'm so sorry, baby. I just snapped. Here's some flowers. Let's go to a really nice dinner. Things are getting better. They try to use that, what's called undoing, remember that defense mechanism, to try to make their abuse okay. And then we're going to have periods of escalation and de-escalation, and we're going to start building that tension again, and it's going to cycle through. Okay. Other types of violence that we may see, aside from intimate partner or spousal abuse, can be violence that's directed towards a family member, a stranger, human-made, so like terrorist attack, things like that. So some risk factors that may contribute to family violence: cultural differences, being a female partner. Males can be abused just as easily, but it typically happens more in women. Being a vulnerable person, so especially when you're trying to leave the relationship, when somebody is dependent, when you're dependent on somebody, things like that. Someone who is pregnant, and our older adults and also our children are a huge risk. Violence is going to be very common within family groups and aimed at each other over strangers. Thing to remember is that family violence occurs across all backgrounds, economic statuses, racial, ethnic groups, everything. There is no one set sign for abuse and neglect. For children, we're worried about a child who's under 4. The perpetrator perceives the child as being different, so maybe if they have a physical disability or if they were part of an unwanted pregnancy. Okay. So For our types of violence, we have physical violence. So, of course, this is shaken baby syndrome, kicking, punching, strangling, actually hitting somebody. We have sexual violence, which we're going to talk about. This is when we talk about sexual assault, but this is sexual contact without consent. Emotional violence is where a perpetrator is going to make the victim feel humiliated, worthless, threatened, and they're probably going to try to separate them from family. So we have neglect, which is failure to provide. So failure to provide food, failure to interact with a child, failure of education, failure to provide your child with an education, failure to receive appropriate medical or dental care. And then we have economic abuse, which is keeping money away, making sure this victim doesn't have resources, things like that. The victim, also known as the vulnerable person, is going to have typically low self-esteem, be very helpless, hopeless, and powerless. They will feel lots of guilt and shame, and they're going to try to protect the perpetrator because they feel responsible. We may have denial of the situation. And for the perpetrator, we're going to have typically use of threats and intimidation, a lot of disciplinarian. We're going to have poor impulse controls, violent outbursts, poor coping, low self-esteem, and likely to have experienced violence as a child. So victims of adverse childhood experiences are likely to become perpetrators in the future. So we gotta break that cycle of violence as well. Looking at our different populations for abuse is going to look a little different. So infants, of course, we're worried about shaken baby syndrome or bruising on an infant before they start walking. Preschoolers, we're going to worry about bruising in weird places, the stomach, the back, the butt, arms and legs, especially in shapes of hands, those spiral fractures. Assessing the mechanism of action when the injury doesn't match the story. So that congruent right there. Assessing for burns, cigarette burns, holding them in hot water. I know y'all talk about this a lot in Mother Baby. Human bite marks and head injuries. That's for our preschoolers to adolescents. And of course, with our older adults, same thing. We're looking for bruises, lacerations, abrasions, fractures, physical appearance that doesn't match the story. As far as our nursing care, we have all states require nurses to report suspected child abuse or older adult abuse, and there are penalties for not reporting. This is where a lot of my students get mixed up. We as nurses in Virginia do not report intimate partner violence. It can make the situation worse. What we do in that case is we provide resources, referrals, safety plan, and crisis intervention. So when we have suspicions of abuse, the things that we're going to do is document the data. So document our assessments very thoroughly. We're going to provide care to treat any injury, so we're going to provide medical attention. We're going to make appropriate referrals if this is an older adult or a child, and we can call APS or CPS. If it's intimate partner, we don't make any kind of report, but we do make a safety plan. Safety plans they help the client, okay, we're not ready to leave yet. But if you ever at 3 a.m., if you decide you're ready to leave and you're ready to go, it gives them a checklist of everything they need to flee in the middle of the night. Because when you're ready to flee, you may not be thinking about it. So it kind of gives them a safety plan, a checklist. Who am I going to go to? Who am I going to call? And what am I going to do? For when they do, if they do decide to leave, they have that. We've given them the resources when they are ready to leave safely. And then, of course, we're going to use crisis interventions to resolve family and community violence. Our crisis intervention, we're going to do things like make sure that our clients are safe from harm, provide first aid, reduce stress, and then as a tertiary, we're going to debrief and things like that. And lastly, we're going to talk about sexual assault. Rape is non-consensual sexual activity, and it can include being done by a stranger within a marital relationship, date, or acquaintance. 9 times out of 10, the majority of perpetrators are known to the partner. It's either going to be acquaintance or spousal or marital rape, not done by a stranger. Date rape is going to be a form of acquaintance rape where parties, they agreed upon, they're all together, and then alcohol, substance uses typically are involved, especially a sedative. Y'all will probably know this as roofing. A couple of those are going to be ecstasy. There's some lorazepams and ketamine that can be used and spiked in someone's drink, and then they can't remember or consent. Big thing to remember, there is no risk factor. And it can happen to anybody, anywhere, at any time. So there is no typical form there. Some of the things that we see after a sexual assault is going to be a rape trauma syndrome. This is typically a maladaptive response to a sexual assault. And this can be a expressed reaction. It's right there. It consists of emotional outbursts, crying, laughing, hysterica, anger. This is you can see their actual emotions are being displayed, whether they be appropriate or not. Controlled reaction is more ambiguous. It's more kind of undercover. This is where they have that calm, blunt affect. They kind of feel numb. They're not really doing anything. We have somatic reaction. So we've talked about somatic before. This is where our body is physically doing something to react to this. Muscle tension, headaches, sleep disturbances, nausea, vomiting, anorexia, things like that. Of course, this can cause acute stress disorder and PTSD, which we've already discussed. So we'll have that. We have compound rape reaction, which is where they develop mental health disorders as a result of the sexual assault, or physical disorders because of the sexual assault. Silent rape reaction is when they don't report or tell, they just keep it all to themselves. A lot of times with this, we're going to have changes with relationships, nightmare, increased anxiety. Changes in sexual behavior. This can go either way. I have seen both, where the person doesn't want anyone touching them, or I have seen somebody who they become hypersexual to try to erase what has happened. New onset phobias, and they're not going to talk about it. Very silent. Of course, as a nurse, we're going to obtain certain laboratory results, things for legal evidence, along with laboratory results for HIV, hepatitis, things like that, and then begin treatment as needed. So we need to, as always, perform a self-assessment, because we need to come in empathetic, objective, and non-judgmental. We are going to assess clients' anxiety, how they cope, and their support systems. We're also going to assess for emotional and physical trauma. We're going to want to provide a private environment. Typically, we're going to have a specially trained nurse called a SANE nurse, a sexual assault nurse examiner, who is trained to perform these things and collect the evidence. We want to provide client safety. We want to remind them that they're safe, be non-judgmental and empathetic. We want to have consent to collect the data, such as a pelvic exam and photos. They do have the right to refuse this. Okay. And they need to we're going to treat injuries and document any care that's given. We're going to be, of course, supportive. We want to minimize the suffering and PTSD that comes, especially if they choose to have an examination done and evidence collected. A lot of hand holding, a lot of reassurance, things like that. We're not going to ask our why questions. You know it's not their fault, and we're going to remind them that. A big thing we need to assess for is suicidality, because this can trigger suicide. And of course, we're going to administer prophylactic treatment for STDs and HIV. We also are going to evaluate for pregnancy risk and give emergency contraception if the patient would like. We're going to see if there's a support system and see if the client gives us permission to call them and bring them in so that they can have their support there. We're going to help them through the acute phase of rape trauma syndrome and provide any kind of resources that we can, and use our listening and therapeutic communication. Afterwards, before discharge, we want to make sure that they have a 24-hour hotline for sexual assault survivors. We want to promote self-care activities. We want to schedule follow-up visits and make sure that they have aftercare, as a lot of times our sexual assault victims do not follow up with care. And that is it for all of that.